Hello everybody, Nelson Vergel here, co-founder of Clinic Optimizers, a company that provides educational programs and support to clinicians in the hormone replacement field. Today I'll be speaking about essentials of human chorionic gonadotropin, hCG, therapy in men. I'm also the founder of ExcelMale.com and DiscountedLabs.com. ExcelMale.com is an online men's health forum in which you can get your answers to most of your questions related to testosterone replacement, erectile dysfunction, increasing muscle mass, decreasing fat mass, exercise, nutritional supplements, etc. DiscountedLabs.com is a company that provides affordable blood tests to most people in the United States without the need to go to a doctor's office. So check out both websites and get some benefits out of this information. Thank you. So this information is not a recommendation, nor it is intended to provide direction regarding diagnosis, treatments, or potential outcomes. Any interpretation of this information should be used by the prescriber at his or her discretion. And the agenda is I'll be reviewing current practices and data on the use of hCG in men with or without testosterone replacement. Beyond fertility, are there any non-fertility or testosterone supplementation therapy related benefits of hCG? We'll be reviewing data that is emerging as we speak. And lastly, opportunities for further research. I'll be suggesting studies that hopefully clinicians can do to develop more knowledge in this area. So human chorionic gonadotropin is hormone naturally produced in the human placenta to maintain progesterone production during the first trimester of pregnancy. And progesterone enriches the uterus with a thick lining of blood vessels and capillaries so that it can sustain the growing fetus. It's a glycoprotein composed of 237 amino acids. It's got two units, one alpha and one beta. The alpha subunit is identical to that of luteinizing hormone, follicle stimulating hormone, and thyroid stimulating hormone. The beta subunit is unique to hCG, and that's the one that gets tested for pregnancy in women. Use of hCG as testosterone therapy adjunct combination. Some physicians are using hCG in combination with either testosterone creams or gels, testosterone injections, or even pellets. Continuous exposure to exogenous testosterone, the word exogenous means testosterone that you provide to your body, may reduce fertility in vast majority of users. Testosterone supplementation therapy may also cause testicular atrophy in 10 to 30% of users. A smaller testicular size at baseline may make atrophy more obvious to patients. Possible effects of TST on fertility and testicular size need to be explained to patients before they get on testosterone supplementation. If these potential side effects are important to the patient, discuss possible use of hCG with testosterone, with emphasis on adherence to 2 to 3 times per week injection compliance. It's very important to discuss this with the patient since it requires a lot more discipline to comply with hCG therapy. In men, hCG mimics luteinizing hormone produced in the pituitary gland to stimulate testicular Leydig cells to produce testosterone. However, it shuts down endogenous testosterone, LH, meaning the body's own production of LH, just like testosterone therapy. So in blood testing, once you provide hCG to a person, to a man, LH blood test will appear as 0. When used in combination with testosterone supplementation therapy, it can potentiate increases in estradiol, hematocrit, edema, and or acne. So these variables need to be closely monitored. Normal lyophilized vials containing 3,000, 5,000, 11,000, and 50,000 units of hCG are made by compounding pharmacies. Pharmaceutical brands are also available at 3 times the cost. Latest data show that some men with testosterone supplementation therapy plus hCG were able to remain fertile. And anecdotal effects on raising sex drive in men, it's also emerging. This is a vial, an example of a vial of 11,000 units of hCG, comes in a powder, and it is also shipped with a bottle of bacteriostatic water, which you have to mix into the powder before injection. It requires refrigeration, so that's also another factor to consider when using hCG. hCG used in males, it may be used in patients for 6 to 8 weeks who have abused anabolic steroids to reset the natural production of testosterone, or men on anabolic cycles. I may not have time to cover this topic today. It may be used in younger males as a sole method of testosterone treatment with secondary hypogonadism. This is an use of monotherapy without the use of a combination therapy with testosterone. All men respond differently to hCG and the ability to boost testosterone production by testes. We'll see some data that indicates that older men and men with long exposures to either testosterone or anabolic steroids in the past may not benefit from hCG as well as younger men with no prior exposure to androgens. hCG may not work well with men who have primary hypogonadism, i.e. dysfunction of the Leydig cells in the testes. Although I have talked to a few clinicians that say it may work actually in some men that may have some impaired Leydig cell function, but yet they still have some function to respond. It may have additional benefits beyond testicular atrophy, reversal, and prevention of infertilities, and I'll be providing details on that later on. So what are the typical clinical doses used out there in the field? And hCG has become very popular in many of the clinics in the United States. It's not popular at all overseas, in Canada or Europe or Australia. Men are still struggling trying to have access to hCG since many doctors do not have training on the subject. This is an off-label use that and a product that is generic. So educational efforts out there are pretty much lacking. For boosting testosterone and maintaining sperm production in men with low testosterone as monotherapy, physicians are prescribing anywhere from 1,000 to 2,500 international units 3 times per week. To maintain fertility in men on testosterone, 500 I use every other day. I'll be showing some data on that protocol. To prevent or reverse testicular atrophy and boost libido, which is an anecdotal benefit, in men on testosterone, 250 to 500 I use twice per week. This is a non-validated dose that is yet to be proven by research. Timing of hCG dosing men on testosterone varies among clinics. There's some anecdotal efficacy of combining hCG plus testosterone in the same syringe. That's actually a protocol that I have developed myself, and you can Google Nielsen Vergel hCG video to show that protocol. Monitoring increases in hematocrit, estradiol, and DHT may be needed. As I said before, hCG adds on to those variables when used with testosterone. So what are the actual uses that are approved or off-label right now in the field? First of all, and the one that is actually FDA approved, is the treatment of undescended testicles in teenage boys. Low testosterone, hypogonadism is the second one. Infertility, testosterone therapy adjunct, like I said before, in combination of testosterone therapy, it's actually an off-label use. Anabolic steroid adjunct for the same purposes of allowing or preventing the loss of fertility while using anabolic steroids, which is obviously they're illegal in the United States unless used for clinical purposes. What they call anabolic steroid post-cycle therapy in men that had normal testosterone to start with, and eventually they do anabolic steroids for a few months, and then they get off and attempt to accelerate the recovery of their natural production of testosterone. As I said before, this is an off-label use. It is a harm reduction use that many physicians are not prescribing, obviously, but patients are accessing through the internet. So I think it's my responsibility eventually to speak about this subject, since it is part of a harm reduction program. Possible improvement of libido beyond the effects of testosterone alone are common. I'm one of them. I would say I have a very strong biases for the use of hCG in combination with testosterone because of the added benefits when it comes to libido and even mood. So are there any other benefits to reactivating upstream hormones? I'll be speaking about what happens when you provide testosterone replacement or supplementation to a man. What happens upstream in the cascade of hormones? So we say that hCG is a mimicker of LH. It's not the same molecule, but it behaves like luteinizing hormone, which is a hormone coming from the pituitary gland towards the testicular Leydig cells that make and produce testosterone. When you provide testosterone replacement to a man, there is a shutdown of LH from the pituitary gland. And providing hCG may actually replace the effects of LH on the body. So as an adult, onset hypogonadism is due to the disruption of central endocrine axis. It has been shown that hCG acts similarly to LH in this pathway. However, hCG shuts down LH. In blood testing, as I said before, LH is basically zero. So some clinicians get confused with this fact. And LH and hCG actually bind to the same common receptor termed luteinizing hormone chronic gonadotropin receptor, LHCGR, which is expressed in numerous tissues including adrenal glands, brain, skin, retina, as well as reproductive organs. So this tends to suggest that there may be an effect of LH and or hCG beyond just testicular function. The non-gonadal expression, meaning the expression outside the testicles of LHCGR, has been shown to be necessary for local steroid production. Diabetes, thyroid diseases, renal dysfunctions, advanced age, inflammatory conditions, stress, etc. support the release of soluble LHCGR from the inflamed tissues into circulation. So nobody really knows yet what this means, but what it means is that the receptor itself may have other functions beyond the production of testosterone in the testes. As said before, LH and hCG attach to the same receptor. There's an alpha unit and beta unit of hCG. Both act, as I said before, on the same receptor. However, they work differently intracellularly. This is the only study that I have been able to find in the literature on the effect of testosterone and or anabolic steroids on upstream hormones like pregnenolone, progesterone, and DHEA. It was actually published a long time ago, 1985, and I would actually love to see this data replicated in 2018-19, since it's, in my point of view, very important. It actually showed that testosterone doses of 200 milligrams a week, there was a substantial decrease in pregnenolone, DHEA, and progesterone in this man that stopped therapy after 26 weeks. And obviously you see a recovery, slow recovery of all hormones after that period of time. So testosterone supplementation therapy and upstream hormones, what are the issues here? When we provide testosterone supplementation, this decreases or shuts down several hormones. Luteinizing hormone and follicle-stimulating hormone are shut down. Pregnenolone and upstream hormones decreases. Progesterone decreases. The testosterone inside the testicles, we call that intratesticular testosterone, decreases. I'll be speaking about how important this fact is. Blood levels of testosterone do not equate to testicular T in men on testosterone. And the intratesticular testosterone is very important in relation to the production of sperm. DHEA can decrease at higher doses, and sex hormone binding globulin always decreases when providing testosterone supplementation. The asterisk shows that these hormones may actually be increased by the use of hCG, which is a hypothesis that needs to be proven with more data. I apologize for the really busy diagram. Basically shows what happens from the point of cholesterol molecule downstream in the production of sex hormones, cortisol, aldosterone, and estradiol testosterone, dihydrotestosterone at the bottom. So cholesterol basically is converted into pregnenolone, which is called the mother of all hormones. Pregnenolone goes into two different paths, one to produce progesterone and cortisol, and another one, like I showed here, aldosterone, which is a hormone that regulates electrolytes and in the body. So where you see the yellow stars up here in the beginning of the chart, the flow chart, that's where luteinizing hormone is needed for activation of that path. When we use testosterone supplementation therapy, LH is shut down. So this may explain why the previous study that I just showed, the 1985 study, showed decreases in pregnenolone and progesterone once men use testosterone and or anabolic steroids. So the hypothesis is hCG able to reactivate this path, this hormone path? Another fact that we need to discuss is that long-term suppression of LH caused by testosterone supplementation may or may not be healthy. Nobody has really looked at this fact. A decrease in pregnenolone, progesterone, those two hormones also have roles in men, although we have very limited data on them. So decrease in them may also have other implications. So LH is needed, as I said before, for activation of the steroidogenic acute protein, STAR. That's the nomenclature here. Also for 3-beta hydroxysteroid dehydrogenase, and for 1720 lyase to metabolize cholesterol into pregnenolone and progesterone. Testosterone supplementation shuts down LH and may decrease pregnenolone and progesterone, and hCG, which is an LH mimicker, may reactivate STAR and normalize this cascade. As I said, this is just a hypothesis that needs to be proven with further research. A study actually showed that hCG increases not only serum and intratesticular testosterone, which is responsible for sperm production, but also increases upstream hormones like 17-hydroxyprogesterone, androstenedione, and DHEA. So there is some indication here from this study that what I just mentioned in the previous slide may actually be happening. hCG decreases sex hormone binding globulin, so it actually increases free testosterone because of that, like any androgen. And could this be some reasons why libido may increase in men on testosterone replacement therapy plus hCG? We don't know. Is this libido enhancement due to increases in free testosterone or increases in the upstream hormones, or increases even on DHT and even estradiol that I'll be speaking about next. So testosterone therapy plus hCG, the effect on intratesticular testosterone, the testosterone inside the testicle. And this testosterone is actually one of the most important factors involved in sperm production. And interesting enough, when we provide testosterone supplementation for a man, either through injections, gels, pellets, etc., we actually increase the serum or blood levels of testosterone, obviously. But due to the LH shutdown, intratesticular testosterone decreases. And that's a fact that I think most clinicians don't really know. In this study, 24 men were given 200 milligrams a week of testosterone enanthate. and also in combination with hCG, placebo 125, 250, and 500 IUs every other day for 3 weeks. Very interesting study that basically set the field into what we're experiencing now using the combination of testosterone and hCG. So these are graphs that come from the study. Sorry, there's a little busy here. The two left-hand side ones, top and bottom, are LH and FSH. The y-axis is days. So you see, obviously, that all doses of hCG decrease LH and FSH, like I said before. The right-hand side one on the top is serum testosterone. Obviously, the higher the dose of hCG, the higher the testosterone. 500 IUs and 250 actually went a little higher than the normal range. And this was, as I said, injections provided on men that were using 200 milligrams a week of testosterone. And the bottom one, the most important graph, it shows on one side the testosterone, and the y-axis, the x-axis, the doses of hCG up to 500 IUs. And you see the bars, the dark ones and the dashed one. The dark one is baseline intratesticular testosterone, and the dashed one is intratesticular testosterone at day 21. The only dose that was able to actually increase ITT over baseline was 500. 250 was very close. So really, a dose between 250 and 500 IU in this healthy male population was able to restore the testosterone inside the testicles to normal levels for production of sperm. So that's the dose of 500 IUs has been adopted by many clinics using combination of testosterone and hCG. After this study, the Baylor College of Medicine group, led by Dr. Lipschultz, decided to run a follow-up study, in this case a retrospective review, of 4 years of men with low T presenting at the Baylor Andrology Clinic here in Houston. And 26 men who were concerned about their fertility, who had been previously provided testosterone creams, gels, and injections, and were prescribed hCG at 500 IUs, as I said before, every other day, with exogenous testosterone. 19 of them were on intramuscular testosterone at 200 milligrams per week, and 7 of them were on transdermal gels at 5 grams per day. For an average of 6.2 months, this was actually the review time for the study. And despite a mean post-treatment level of testosterone of 1,055 nanograms per deciliter, the seminal parameters of the semen, count, motility, and morphology, did not significantly change during the period of observation. What does that mean? The addition of hCG to testosterone replacement actually prevented the decrease of sperm count, motility, and morphology of the sperm. So that was actually, even though it's a small study, it really set the pace for what we are experiencing in the field right now. Not, as I said before, not every physician agrees to prescribe hCG with testosterone, mostly because of lack of education and lack of knowledge of this data. So the Baylor study demonstrated the ability of low-dose hCG to maintain spermatogenesis despite the administration of exogenous testosterone. And this is just more data from that study that to show all the different variables they followed through the study itself. However, after further analysis, this was actually presented later on by the same group at Baylor. They found that hCG in combination with testosterone did not work as well for everybody. Older men with a lot more longer exposure, pre-exposure of testosterone in the past, had lower efficacy or response when it came to total motile count of sperm. So this is something very important to know, that even though we have promising data on the combination of hCG and testosterone to preserve fertility in men, this combination may not be effective for everybody. And there are other ways to improve fertility in men with lower response, like using clomiphene and combinations of hCG, or even follicle-stimulating hormone, which is also sold by compounding pharmacies, and combinations of all that. So this is just one approach, and obviously it's not an approach that works for everybody, but it's definitely promising, especially for younger men, 20s under 30s, that are starting testosterone replacement and want to preserve testicular function and sperm count. And this is a very interesting algorithm used by Baylor. It is not a common algorithm used in the field, I have to say, because I was pretty surprised when I saw this data, which was presented in 2015 by the same group. Dr. Ramasamy is a urologist and now works in Miami, but used to work with, used to be a fellow for Dr. Lipschultz in Houston. But anyways, the top step here is a man coming in desiring to maintain fertility while starting testosterone supplementation therapy, TST. On the left-hand side, you see, yes, they definitely want to keep their fertility. We'll go down that way now. Is pregnancy desired soon or mid-range or long-term? On the left-hand side, you can say less than 6 months. You can see that. And this group recommends to stop testosterone supplementation and actually start higher doses of hCG monotherapy every other day, with or without clomiphene, depending on the patient, until the third trimester, with semen analysis done every 2 months to make sure that this protocol actually works. Semen analysis remains suboptimal, considering adding FSH to this protocol. For mid-term, kind of 6 to 12 months desired for pregnancy, they continue testosterone, and they add 500 IUs of hCG every other day. In some men, they may actually even add clomiphene for an extra boost there. And long-term, like over 12 months of desire to attempt that pregnancy. This is kind of the most interesting side that I haven't seen before. They cycle off testosterone on this man every 6 months, and they provide instead a 4-week cycle of 3,000 units of hCG every other day. There is no, as I said, there's no data whatsoever on this approach. I even talked to them this week, and they just say this is anecdotally something that is working for their patients. So, but as I said, every clinic is using different protocols, since there are really no guidelines when it comes to the combination of testosterone and hCG. On the right-hand side, we have men that do not desire to maintain fertility in the setting of TST. They desire there's a periodical cycle of testosterone approach that, as I said, Baylor uses sometimes. They prescribe testosterone supplementation for 6 months, then they switch to a monotherapy of 3,000 IUs of hCG every other day, and for 4 weeks, and then they go back into testosterone supplementation again. The rationale is that, basically this stimulates the Leydig cells for short periods of time. As I said, I have yet to see data that this is more effective than just using testosterone supplementation plus hCG in a constant manner. All right, so let's move on. So, as I said before, hCG plus testosterone may not be effective for all men that want to remain fertile or increase their fertility. So, in this population, the use of recombinant FSH, follicle stimulating hormone, which is a very expensive pharmaceutical product, but that can be obtained more cheaply through very few. I think there's one or two compounding companies in the United States are making this product. So physicians may actually prescribe hCG in combination with FSH to improve fertility in this men. And I'm not going to go through this table, so I'll give everybody a headache, but it's a review of different studies published as far as back as 1984. This is not, the last study here is 2010, so there have been some more studies since then, but the recovery of spermatogenesis anywhere from 50% to 100%, depending on the population. The dose of hCG, which as you can tell is variable here, the frequency of injections of hCG, FSH dose, and the frequency of injections of FSH. So this is, as I said, fertility is a fast-moving field that in which protocols really are dependent on the person's history more than the protocol itself. This is a very interesting case, history posted by Dr. Justin Saya from Defy Medical in Tampa on my site, ExcelMale.com. I have a few doctors that post very interesting information, and they also answer questions on my site. There are over 16,000 men registered there, but we have over 4 million page views a year, so it's becoming really popular. Very, very happy about that. But anyways, he gave somebody, and this is one single person, 150 IUs of hCG and also 500 IUs. And he measures they measured the beta hCG blood levels. This is a simple pregnancy test, basically. And excuse me, and obviously with a higher dose, there was a higher increase of beta hCG, but also a more sustained concentration of hCG. So this is relevant to know for consideration in comparison of quantitative serum beta concentrations with endogenous luteinizing hormone concentrations in a typical normal range for is around 1.7 to 8.6. This is very important, especially, and I haven't mentioned this, some cancers, like testicular cancer, can actually produce hCG. And that complicates matters. Let's say a man has testicular cancer, is treated for that cancer, the cancer goes in remission, and obviously, usually men with testicular cancer end up being hypogonadal, and they require a testosterone replacement and or hCG for the testicle that remains healthy. And so it's very, very difficult to know whether an increase in hCG blood levels is caused by the return of cancer or the dosing of hCG in that man. So this was a very curious case that Dr. Saya was kind enough to share with us. And this is definitely a topic that is discussed a lot on online forums like mine. Excuse me. hCG, just like testosterone, increases obviously estradiol blood levels and testosterone. The higher the dose, the higher their concentration, obviously. This is really a no-brainer. But another study actually gave me a very interesting view on this matter. The dose used here was 3,000 IUs of hCG daily for 3 days. And an estradiol was measured in this man. And you could see an increase in estradiol and then slower return to, I wouldn't say baseline, but lower levels, even though we're injecting hCG 3 times in this study. So there may be a stabilization after a while in men using hCG, and in this case, that's obviously a higher dose, that 3,000 IUs instead of 500 IUs we're using mostly with testosterone replacement therapy currently. So I will, in another webinar, because this is getting a little long, I'll be speaking about harm reduction strategies for current or former anabolic steroid users that are requiring to normalize their fertility and testosterone after they use these compounds. So potential studies that I see needing in this field are the first one, looking at the effect of testosterone supplementation, hCG, and their combination on upstream hormones like pregnenolone, progesterone, cortisol, and DHEA. That's very important. We need that data. So if anybody out there is listening or watching this video and want to get in a hold of me, you can find me through clinicoptimizers.com or ExcelMale.com or discountlabs.com. And I'll be more than happy to give you some ideas on how to design this protocol. The second one is looking at the effect of addition of hCG to testosterone replacement or supplementation, on self-reported libido, testicular size, and mood in men. Even though we're using hCG for all these three benefits, we have little data on the subject. So we need to formalize this benefit so that more physicians are more open to prescribing hCG to men that are currently extremely frustrated and venting on my online forum and also on my testosterone replacement discussion Facebook group, which also has over 13,000 men. The third one is looking at the effect of the addition of hCG to testosterone supplementation on sensitive estradiol and DHT blood levels in the longer term. So I showed data that only really looked at a few days of injecting daily at higher doses. We definitely need long-term follow-up data on men on hCG monotherapy and also on the combination of hCG and testosterone to assess any potential hCG desensitization, which some men are worried about. I've used hCG for over 4 years, and I cannot say that it has stopped working when it comes to libido and testicular atrophy prevention in my case. Excuse me. We have absolutely no control data on optimum hypothalamic pituitary testicular axis normalization protocols in men, former users or current users of anabolic androgenic steroids. So, as I said, I will be covering that topic in another webinar since I do not want to keep you guys longer than I should when it comes to watching this webinar. So, thank you so much. Stay tuned because you can actually find more videos on the YouTube channel for ExcelMale. So just Google that, ExcelMale YouTube, for over 75 other videos that hopefully you guys will like. Thank you so much, and we'll see you guys soon. Bye.